This program is brought to you by Emory University.
Okay, good morning. Thank you everyone for being here. As you can see, our speaker this morning is Matt Topel. Matt is he's in his 5th year. He did our fast track research track, which means he did 3 years of research, and now in his 2nd clinical year. Matt went to Duke University for undergraduate, did his medical school here at Emory, and then his residency and fellowship here as well, much like myself. So he's going to talk to us, as you can see today, about artificial intelligence in cardiology. Matt.
Thank you very much, Dr. Williams. So it's a pretty straightforward title, not a whole lot more that I'm going to offer at this point, but thank you all for being here this morning, and I'm glad that there's coffee and that I have a voice this year as compared to last year, which I did not have. I have no disclosures about this talk. I don't own any stock in any of the companies that are doing any of this work. I picked this topic just with very little to no background in AI other than how we all use it. My phone knows where I'm going before I do. I magically see ads pop up for things that I just randomly mentioned in passing. I used to have an Amazon Echo, but turned it off because it freaked me out. So this was really sort of prompted by the fact that, every other week I feel like there's a new article, review article, original manuscript coming out about the integration or the utility of artificial intelligence, specifically in our field, but obviously it's throughout medicine. So I'm hoping that we can kind of get into sort of what is AI, how it's being used, and where this all may be going. And if you notice, I didn't title my talk, the machines are coming for us all, or the next greatest thing in cardiology. This is hopefully going to be a fairly neutral, fact-finding sort of talk. I'll leave the editorialization to the last 15 minutes, hopefully. So just to start, I don't really have a presentation, a clinical presentation, but sort of a scenario, just a routine clinic appointment, and to think about how things are done sort of currently versus how some of these technologies that we're going to talk about today may be utilized in the next 20, 30, 50 years, however long it takes. So typically a patient comes in, fills out an encounter form, updates information, they manually have all their vitals checked, those get manually entered. The nurse or MA confirms medications, have you been out of the country in the last 30 days? All of these things get manually entered. The provider, goes and pre-charts, so you look through what's been going on with the patients since I last saw them, what are my communications with them, have they been admitted to the hospital, what have other specialists been seeing? You then synthesize all that data as best you can, put it into your note, bring it up in the discussion. Then you have your clinical encounter. Some of us are sitting at a computer, probably all of us now are sitting at a computer, doing a lot of typing, trying to maintain eye contact as best we can, charting while we're in the clinical encounter, and then at the end, sort of finding the orders that we want, pointing and clicking, typing out discharge instructions, and then finally having the patient leave clinic. In the actual encounter, maybe you're looking up references, maybe after the encounter you're looking up recent trials that you're like, oh, I remember seeing something about that. Are they eligible for a clinical trial that's at my site? Do I need to fill out prior authorization forms, and then ultimately billing as well? So all of this is done manually, human-based at this point. Main objectives for today are to sort of describe and define very basic architectures of what AI is, and specifically machine learning, and then to discuss just a smattering of recent applications using AI in the practice of cardiology, and then at the very end to talk about some of the challenges with AI integration, specifically within the practice of cardiology, but more to medicine and healthcare in general. Unfortunately, we have to kind of start with some basic definitions, so we'll try to go through these relatively quickly. Artificial intelligence, when we use that term, basically we mean a computational program that's sort of performing autonomous decision-making based on collected data. So in sort of the human-machine analogy, this would be you. You're the artificial intelligence. You're actually making decisions based on all of your data. Machine learning is really the way in which this happens. This is a lot of different computational techniques that allow artificial intelligence to occur. There are actually multiple machine learning algorithms, one of which we'll talk about today is sort of an example that's used a lot in the literature that actually models brain activity in the human. So this is really similar to your brain, the nervous system. And then features are a very important part of machine learning. So features are subsets of big data, quote unquote, big quotes, that sort of describe specific characteristics. In imaging, you can think of things like pixel density. In sort of dynamic imaging, you can think of vectors. These are used in machine learning to identify smaller subsets that then eventually go in to describe a larger context. You can think about the fact that you can, generally for animals that are on four legs who have like a tail and characteristic ears and face are cats in general, but you're able to tell like the type of cat, puma versus lion, same cat, dog, they're on four legs, but they look different. You're able to kind of tell that based on different features of those animals. There are kind of two buckets here and a third that I'll mention that's not listed here of how these machine learning algorithms work. So supervised learning is a classic way. It's iterative data analysis that's structured by selecting features with sort of a pattern of finding a way to fit all of your data into an outcome of interest. And this is sort of in thinking about how we currently use this in frequentist statistic modeling. This is sort of your traditional logistic regression or any type of regression. In machine learning, and this is the example that we'll talk about in a little bit, one of these examples is something called a convolutional neural network. Unsupervised learning is kind of where a lot of the talk of AI and how it's going to be used going forward is centered on, and this is sort of that black box. You're just feeding data into an algorithm. There are no a priori assumptions. You're not selecting data features to try to fit to an outcome. This is really a method to identify hidden and really non-linear, non-traditional relationships between different variables. We do have these methods in traditional statistics. These are things like principal components analysis, where you just give data and you're trying to figure out buckets in which sort of observations or subjects might fit. In machine learning, there again are multiple methods for doing this. Hierarchical clustering is one of them. We won't go too much into these, but a lot of times unsupervised learning outputs are then used for supervised learning algorithms. So none of these things are in isolation. Frequently, all of these tools are used together. There's a third type of broad category called reinforcement learning, and that's where the algorithm, sort of quote unquote learns how to act in certain environments based on feedback and adjusts decision making accordingly based on a defined success or failure. You can kind of think of IBM's Watson application for how this is being done. This is not really into being utilized much in cardiology or healthcare yet, although there's a lot of interest in it, obviously. I personally may date myself, but I think of sort of the Matthew Broderick movie War Games from 1980s about, a learning machine, learning algorithm. So that's kind of very basic three buckets of the type of learning that's done for these algorithms. Things that we won't go a lot into today, but I think you've probably either experienced or heard a lot about that are part of the field of artificial intelligence are called natural language processing and computer vision. So natural language processing is sort of a branch of AI that's focused on organizing unstructured text to then be able to abstract things out of that unstructured text that you want. So I want to be able to find this exact type of patient with these things for my study. Well, you feed your EMR data into your algorithm and it pops out a potential list of patients for your study. There's actually some work being done to record clinic conversations between a patient and a provider and for it to abstract out a full review of systems. Different review systems are better than others, but that is being looked at as a possible utilization of natural language processing. Computer vision is your Tesla automated driving. Okay, so it's using visual data to basically constantly update outputs and react to those outputs. So this is sort of coming down the pike. It's already out in real world practice, and there are a lot of emerging data on how to use this specifically in like ICU settings to monitor what's going on with patients. We won't talk a lot about either of those two things. For me, it was really helpful to learn that the concept of machine learning isn't really new. It's just that computational power has really grown over the past 10 to 20 years. So on this chart, this is kind of the human machine learning continuum. So here you have data sample size, so from 1 all the way to 10 to the 10th power. And then here you have fully human-based all the way up to fully computer algorithm-based. And kind of down here, this is sort of your typical clinical experience. So you have, 1 to thousands of experiences working with patients in the clinic, and all of your decision-making is you. Sort of traditional observational data to create risk prediction models, randomized control trials. These are utilizing things like regression analyses. Obviously, that is a type of machine learning. You are defining features for which to fit an outcome. But still, most of the analysis data interpretation is being done by humans. As you move further up and to the right on this, you get more into what we're really thinking now is machine learning, artificial intelligence, and until you kind of get all the way up to this. This is called generative adversarial networks. We're not going to go into those either today, but this is like a fully automated, no human input algorithm in which most of its applications are being used to improve image quality of images that are already sort of there. So to talk about this a little bit, I want to go into just a brief example of convolutional neural networks, CNNs. I'm sorry? No audio. So this is a video that's available through JAMA. JAMA's got a great sort of series on artificial intelligence, and I have the link at the end, but I've kind of taken a couple bits of this. So a CNN is a type of machine learning process, deep learning, both supervised and unsupervised learning. So it's not really one process. It's a complex network of sort of interconnected processes organized in these layers. And each layer can detect higher and higher levels, more abstract features. And when it's doing that, it's using these things called filters. So when you think of specifically imaging, that's the way that CNNs are frequently used. Imaging, all types of imaging, really. Radiology, dermatology, pathology slides, they're really just defined by local structures, right? Shading, textures, contours, corners. You kind of think about it like finding the pieces of a puzzle when you've got like a 10,000 piece puzzle in front of you. You're looking for tiny little signatures or filters with which to put the entire puzzle together. Those building blocks are the convolution. It's really a very complex mathematical equation that I'm not going to put in front of you. I don't understand it, but the concept's really simple. You're going to take these convolutions or these little sort of filters, and you're essentially going to walk over your image and decide, is this filter similar to what the image is? So you're walking across your entire picture, and when you do find something that is similar to it, you generate a signal. And if you don't generate a signal. And that's how you create feature maps that then get used to make decisions. So for images, this is a retinal scan. And I'm sure many of you know kind of the first big breakthrough was the Google AI team using retinal scans to diagnose diabetic retinopathy and the severity of diabetic retinopathy. And this is now an FDA-approved algorithm that can be used for this purpose. So you can see these filters, kind of what we're talking about, textures, contrast, edges. These are sort of the building blocks of the picture. And as the CNN kind of goes higher up in its hierarchical sort of structure, it looks for different combinations of these filters, and they get more and more complex with each layer that you go through. And as it becomes more complex, it gets closer to finding its actual target output, and it's able to identify what you've trained your model to find. So in this case, severe non-proliferative diabetic retinopathy. So this is a hierarchical method of successively more complex layers to get to your final outcome. There really is not a lot of difference for how we do specifically type of prediction between this and more of our more traditional frequentist statistics prediction models. So what we need to do is we need to train our model, and then we need to test our model. And the most common way of doing this kind of across most studies in cardiology, at least that I've looked at, is what's called X-fold cross-validation. So you have some sample size. Hopefully it's very large. Often it's not on the order of hundreds of thousands or millions of observations. So you actually sub-segment your data into two different sets. And within your training set, this cross-validation allows you to partition out pieces. In this case, in fourfold, it's 75, 25, tenfold, it would be 90%, 10%. But you're basically running iterative analyses on your model so that you end up being able to use your entire data set to derive your model. And then you take that model and apply it to a withheld or a test data set still within your data set. So it's still, all of this is subject to the same sorts of biases that traditional modeling methods are. You can overfit your model very easily, actually, with machine learning if you're not taking into account some of these limitations. But this is the best way for these algorithms to minimize bias to eventually get to the best fit model that they can. So this is sort of a proposed workflow of machine learning in one of these review articles, and I think there's really no specific AI or machine learning step, right? So you have data sources. These data sources are coming from everywhere, okay? From the clinic setting, from the environment, from 23andMe, from wearable devices, from pharmacies. These are not unified data sets, and actually a lot of what machine learning is being used to do is to try to figure out ways to call that data and to clean that data autonomously so that humans aren't actually the ones doing it. So AI is used in just the cleaning of the data, the feature engineering, and then actually deciding what machine learning algorithm should I use. And it's not saying I need to use X, it's what combination. These are ensemble methods. These things are used together. Just like you can't use any model you want to analyze data in an observational data set, certain types of machine learning algorithms are not built for certain types of data. So you need to have people who have specialized in this to decide how you're going to go about analyzing. And then it gets into model development. And this part down here is probably what I think is the most important. So as you develop your model, you're evaluating, predicting with your own data, but this very important step, and what I think some of the best data out there, that's what they're doing, is they are involving new observations continuously. Probably the best example of this is how machine learning and AI is being used in hospital readmission risk prediction. So you build a model based on historical data, and then you're continuously updating your model with inputs from current discharge data, discharge and readmission data. And so that's how it has to work. A lot of the studies that I'm going to go into don't really necessarily do that because they're just sort of proving a point of concept. But practically, that's how most of this is going to have to be used. So I'm going to go through a few current examples of how machine learning, some of them you've probably seen out there, come across your Twitter timeline or in the blast that we get from 17 different emails about what new data is coming out. But this is just a small subset of examples. And I'll start with just a schematic that I think is kind of funny because all the arrows go to everything. There's no flow of process. I'm not really exactly sure. I like this because it kind of gives you some keyword, buzzword things, but there's really no utility in this graphic whatsoever. Essentially, their takeaway is that everything is going to be involved with artificial intelligence. But you can see, so these are big buckets, and these are the things that are in active research. So novel therapeutic agent discovery, disease stratification, specifically precision medicine. And I think if I would take anything away from this talk, AI and machine learning is truly what I think most people mean when they talk about precision medicine, whether they're using a specific type of data or not. This is the machine that will power the ability to do precision medicine as it's currently visualized. Integration of omics data, sort of the extension of physician efficiency and efficacy. I'm not 100% sure I totally agree with that, but we will talk about it. And then resource allocation, optimization, and then monitoring and diagnostics. They're really kind of, in my opinion, a few big buckets. So imaging is where it's traditionally and it's started, and I think this is the most robust data that exists. There are multiple reviews in JACC imaging, main JACC for imaging applications, but image process and quality, image segmentation and measurement and interpretation of data. AI is being used for all of these things across all modalities of imaging: ultrasound, CT, cath, and MRI. Risk prediction is the other big bucket, traditional thing, predicting clinical outcomes, predicting responses to therapy, and then preventing or predicting readmissions. And then process efficiency, like I mentioned, note or report generation, real-time decision assist devices, and then administrative tasks like billing, scheduling, et cetera. So I'll start with some examples. So the first example I'll talk about, the question that was asked by the group is, can AI determine the make and model of a cardiac device with just a single chest X-ray? Their reason for doing this is mostly, again, proof of concept, but cardiac devices are very common, and individuals don't always go to the same institution where their cardiac device was implanted. So knowing the manufacturer, at the very least, is super important, obviously, for being able to interrogate the device. And then algorithms, quote unquote, for determining are out of date and don't include newer devices. This is the algorithm. I don't know if anybody has seen this from Device Clinic at Grady. This is kind of, it actually works really well. I'm not going to knock on this algorithm. This actually does very well if you have the time to kind of step through it and look, which you usually do, if we're being honest, right? There's usually not an emergency where you need to know exactly what the manufacturer of the device is in 10 seconds. But it is cumbersome and it is older and doesn't include all data. So what this group did is they took 20 years of data from a National Health Service site in England. So a single study, but they took thousands of images. So really not that many, 1,600 images from 1,500 patients. And what they did is, for a device to be eligible to be part of their algorithm, there had to be at least 25 and not more than 40. And the not more than 40 is important because if you get an imbalance, then you risk overfitting your model again. So this goes back to similar problems that we've had in the past. What they did is they subsetted their image to a square 224 by 224 pixel image, and then they actually trained and assessed 5 different CNN algorithms to eventually figure out which one performed the best for their specific task, and then they retrained that model that performed the best. So there were kind of multiple steps of training, and this is where that algorithm came from before. So they used fourfold cross-validation, finally trained the model, and then validated it on a separate set of 225 images where there was 5 images for each of the devices. And what they found was the algorithm did really well. So the algorithm, the neural network, was 99.6% accurate at identifying the manufacturer and 96.4% accurate for identifying the model. So not just the manufacturer, but also the model. Human accuracy, kind of ranged from the 62% to the 88%, and they used sort of 3 cardiologists, general cardiologists, and 2 EPs. And so obviously the EPs did better than the general cardiologists. The general cardiologists, were in this 62 to 72% range. But the neural network performed better than both the EP and the general cardiologist. There was only one misclassification across the 5 major device manufacturers. The accuracy did decrease to about 90% when they used portable versus, lab radiology department generated images, going to the point that the data that you put into these models is important for what your output's going to be. So sort of if you have bad data going in, you may get bad data coming out. I thought the reason I chose this one is they kind of let you under the hood a little bit because they show you some of their feature maps and how these algorithms actually make decisions. So this is supposed to be interactive. There's no grading. So there are 2 pairs of devices that are similar. So 2 of these devices are similar, 2 are similar, and they're separate. So A is similar to either B, C, or D. So I want you to look at it just for a minute and figure out which one you think, just looking at these, and I know there's light and it's not perfect and some people are far away, but if you think A is similar to B, raise your hand. If you think A is similar to C, raise your hand. Okay. If you think A is similar to D, raise your hand. Okay, I am an A and D person. So it's actually A and C and B and D. And these are sort of their feature maps. This is what I was saying when they kind of go through and give you intensity signals. This is what the algorithm is looking at. So this specific signal of this node is what made these 2 things similar. And I think this, to me, sort of identifies that, the human eye is very good, but that is a very subtle finding that I certainly, even after knowing what the answer is, I've gone back and looked, and I haven't 100% appreciated that every time. But the neural network is able to get it. So this is also a really cool paper because you can actually go to their website and put in your own data. And I didn't make sure my images were 224 pixels by 224 pixels. I cropped pictures of devices from my Grady clinic. So I wanted to see if my Grady clinic images are able to perform just as well as everything else in here. So this is just a random cropped, obviously you can see it's not a square. I did not follow their instructions, but I fed it into the algorithm, and this is what their algorithm prints out. So I am 100% confident of it's one of these 3 things, and really it's just this one. So this is a St. Jude, Quadra Assura, or Unify. And this is a St. Jude Quadra Assura device. So this is the device. It's not always 100%. So this is sort of a grainier image. There's a line down here. So there's some artifact within the image. So its confidence is not as strong, but it still gives you a tiered prediction, and it's still right. So I obviously didn't do this hundreds or thousands of times, but I thought it was a nice demonstration of how this may be used going forward. What are the implications of this specific study? I mean, I think, unless you're, incapacitated and unable to take a cart with 4 device interrogators to a patient, or you just don't have the time to do this, then it's probably not that big of a deal, right? But it's more of a proof of concept and a way to demonstrate how some of this might be used. A very big article that just came out last month in Lancet is looking at the question of, can we predict individuals who will go on to develop AFib from a single normal sinus rhythm 12-lead EKG. The idea being that there are subtle architectural changes in the heart that are taking place that are probably being translated to the surface electrocardiogram that we aren't really appreciating, but that a neural network or a deep learning algorithm might be able to do. So they used a CNN, like we talked about, to develop a probability of AF score. And they used the Mayo ECG lab data. They had a total of 650,000 normal sinus rhythm EKGs from over 180,000 patients. And they sort of trained it on 70%, validated on 10%, and then withheld a 20%, so a fifth of their population for testing. The mean age is the demographics are pretty representative. Mean age 60, half were female, and then 8.5%, so not quite 10% of people ultimately ended up having AFib on at least one EKG. And what they did was they wanted to look to see what is the likelihood of a normal sinus rhythm EKG being able to predict future AFib, knowing that at some index event EKG, they went on to have AFib. So the answer is very, very well. Their main analysis was really looking at the first normal sinus rhythm in the window of interest, which was 30 days before to all the way, to the last EKG that they had after the index ECG. And the AUC was 0.87, very highly sensitive, very highly specific. To give a sort of reference, when we use Chad's VAS scores for predicting stroke, anywhere from 0.57 to 0.72, similar limitations for using BNP for heart failure and pap smears for cervical cancer. So very highly sensitive and specific. When you actually use the highest scored EKG in that window, the sensitivity and specificity go up a little bit. So, again, what are the implications? How can this be used? Well, I think this gets into a lot of how are we going to use all of this new data that we have if we're starting to diagnose people with diseases that we don't know if they're ever going to end up having. In the article, the authors really push this application and implication more towards in somebody who may have had a stroke already, who's in sinus rhythm when they get there, and who's in sinus rhythm while you're monitoring them. Do you have EKGs either at the time of admission, before admission, or after admission that you can use to then say, okay, this person has a very high probability of AFib. Let's actually put a loop in them, or let's actually put a Holter on them and anticoagulate them in the meantime, because just anticoagulating everybody with ESUS doesn't work. Like that, there's no benefit and just harm. So maybe this gets at actually identifying a higher risk subgroup of people for which we can intervene on and more closely monitor. I wanted to shout out Dr. Samity. So this is a way that a lot of AI and machine learning is being sort of learned or transitioned into the cath lab, and this is something that Dr. Samity's group presented at TCT last year, looking at an AI-based IVUS segmentation compared to expert measurement. And again, sort of the benefits of this is it happens in a fraction of a time. So there's not moving away from the patient, moving away from the case, going in and actually trying to draw borders. While you're doing this, the patient's still on the table, or you're doing this post hoc after the fact. So there actually is excellent agreement. You can see that. There's excellent agreement between expert human identification of borders compared to the machine learning. Again, this is all getting at borders, right? So machine learning is very good at identifying subtle changes in image, borders, structure, and so these perform really well. And actually, the only place that it doesn't perform particularly well is when there is a lot of similar looking pixel sort of density kind of right in this area. So you can see the algorithm doesn't perform quite as well as what the human would. So again, this is all about data sort of quality and integrity. So the fourth example that I'll go into, and this will be the last one for the sake of time, is can a machine learning algorithm improve upon sort of the established risk prediction protocols for chest pain in the ER? Huge topic. It's going to get bigger at our institution as we institute high sensitivity troponins. So these investigators looked at actually defining their features. So they're doing supervised learning, and they defined their preset features of just age, sex, high sensitivity troponin at index, as well as the change and the time of the next troponin check. So those are really their main algorithmic features. Their sort of motivation for doing this is a lot of the current algorithms are just there's a cutoff, there's no implication for how old you are you male or female, and it's known that these things are nonlinear. There are differences between men and women, there are differences based on age, and really we're probably missing a lot of things by just creating a one dichotomous, sort of this dichotomization of data problem that we run into a lot. They use something called a gradient boosting algorithm, which we haven't talked about and which we won't, but it's another type of machine learning to predict the likelihood of type 1 MI during their hospitalization. So it was trained using 10-fold cross-validation in 3,000 subjects, and then they actually tested it in 8,000 subjects. And this was done in New Zealand, Australia, and it was done at different sites. So a lot of the data that I've shown you today is a lot of data from single centers. This actually does use data from multiple centers. So from that standpoint, it's maybe a little bit more robust. And not only did they want to just know how does our model perform, but they also wanted to have some comparison to what's already being done. So they compared their algorithm to what is sort of the ESC 01 and 03 hour pathways. And not surprisingly, their model performed extremely well. This is a common thing in all of these machine learning algorithms. They have excellent AUCs, 0.963, excellent calibration, as you can see as well. But what I think is really interesting is it did much better than the 0 to 3, much better is a relative term, but it did better than the 0 to 3 hour ESC algorithm. So it was much more sensitive to ruling out low-risk patients with the machine learning algorithm, which they titled MI3, which I thought was kind of interesting also. But very sensitive, highly specific, about 96% for specificity, compared to the current ESC algorithm, which is only about 82% sensitive for ruling out. And really, that's the main thing I feel like, our main goal for when patients come in and we're doing this sort of rule out pathway for MI. You want it to be very highly sensitive, and their algorithm did a really good job with this. When you actually do the 0 to 1 hour comparisons, they're pretty similar, the ESC versus the machine learning. So no worse, if not just a little bit better. And these guys are a little bit ahead of the game. They've already filed their patent for an app, because that's where everything will go, obviously, right? So you want to use all of this data to develop an app. So you're able to input the patient's age, the time of the first troponin draw, the level of the first troponin draw, the time of the second one, the level of the second one, and then it outputs a continuous risk. So this doesn't include low, intermediate, high. This just gives you a continuous risk, and it lets you visualize kind of what is my likelihood of having this patient go on to have an MI, this hospitalization. So going back to this, we just touched the surface of what a lot of this is and have glossed over a lot of where I think most of us are used to hearing about this data, specifically in imaging. So, but it really is being looked at in almost all aspects of cardiology that we're practicing in. This is probably like a multi-part series in trying to identify and assess different challenges for AI integration. So I'm going to come to the ones that I think are probably the most prominent, and then I would love to kind of start a conversation about what other people think. So, there's sort of an established understanding that for the most part, when we do analyses the way that we've traditionally done them with frequentist statistics, we have well understood methods for evaluating how our algorithms perform. And with machine learning, it's moving that direction, but there is heterogeneity in how we're actually assessing the performance of these models. The thing that's actually driving standardization of this are like data science competitions, which is really interesting. But they have computer science people come to Switzerland and perform in teams, and they're just given data, and then they have to answer a question. These aren't physicians, these aren't anybody who's involved in clinical care, but they need some guidance on what they're going to be measured on. So that's actually how a lot of the standardization is going to be happening. Clearly, integration of data streams and the quality of data is probably the biggest barrier to this problem, or to this technology actually taking off. I mean, we think about utilizing EHR data, wearable devices, imaging data, omics data. These are all coming from different places. We have a hard enough time trying to just find things within our own EMR and use the minimal support structures that are in Epic or Cerner to even find the data that we want. I think it's very, very optimistic to feel like those barriers are going to be sort of knocked down in the near-term future. But that's a problem that a lot of people are working on. There are issues of privacy and issues of how do we protect patients' information that are further going to be complicating that. And then there's cost. So healthcare spending, depending on where you look, is anywhere from a $2 to $5 billion industry currently, predicted to be anywhere from a $30 to $75 billion industry in 10 years, not even 10 years. I took this sentence from an article, just sensors, artificial intelligence, big data analytics, and blockchain are vital technologies for the Internet of Medical Things as they provide multiple benefits to patients and facilities alike. If you think that sentence isn't worth like $15 billion just by itself, I mean, I don't know. That is just like the most jargony, like expensive sounding sentence I've ever probably read in my entire life. So cost is going to be, this is just another avenue of healthcare spending that we currently aren't even really including in what we consider to be excess health costs currently. So another great review, I took this directly from it. It's important to note that these new algorithmic decision-making tools come with no guarantees of fairness, equitability, or even veracity. And I thought that was just an unbelievably good way of summarizing what most people probably fear from the rapid integration and use of these things. So there are myriad sources of bias. These are only 3, and this is adapted from their paper. Missing data, sample size, issues, misclassification or measurement error. And these all would differentially impact vulnerable populations. So people who aren't going to the same healthcare system for all of their care, maybe a little bit more itinerant, they are going to not be represented in these data sets, and their data is not going to be used to derive the outcome or predictions of interest, and they are unlikely to benefit from these technologies. Patients who have rare genetic diseases, clearly, I mean, it's the same problem that we have in traditional statistics. You're not going to be well represented, and it's not a problem of overfitting, it's a problem of underfitting. We don't have enough data points to push the care paradigm for what these patients would need to be included in these models. And then clearly, patients who are at, have low SES, they're more likely to be seen in teaching academic clinics. I thought this was really, I kind of was offended by this quote, but it's probably true. Data input may be less accurate at teaching in academic clinics. And that's true. When I see a patient in clinic, my first thing is not, am I accurately, maybe it should be, but it's not, is their problem list exactly accurate based on what I saw them for today? I want to make sure I get them seen and make sure their medicines are in. That is the last thing that I'm caring about. So that may be true. And so one of their points was that algorithms may learn to incorporate the biases of humans and treat people at low socioeconomic standards differently. And that's kind of true. That's already being seen. Facial recognition software by Amazon is biased against people of color and women. That just came out. There are programs that have been developed for judges to use in determining how long sentences should be for different offenses based on the risk of recidivism, but that is been shown to be racially discriminative as well. So the biases of humans are built into these models, and that's something that is going to definitely have to be addressed. The ethical considerations for AI are myriad, and again, could probably be its own talk, but you can build algorithms to work in unethical ways. And some of the examples that have been sort of discussed in various papers that I read were clinical decision support tools for maximizing resource utilization and reimbursement. So you can find ways to justify and find a reason to do a test that may not be a 100% indicator, or which the patient doesn't really need, if you're motivated by generating profit for your institution, for yourself. Enhancing quality metrics using these algorithms without actually affecting quality of care in an effort to make your hospital look good or to have public reporting outcomes look better. So there are ways in which these could be used sort of unethically. Patient privacy and ownership of data, I think, is going to be a huge roadblock in terms of bringing the public on board with what multiple people in the field want this to get to. I told you I threw away my Amazon Echo. It kind of freaked me out. I think that the idea of privacy and patient sort of ownership of all of their data is probably becoming more archaic and unlikely to be a reality. And so as we do that, we have an obligation to kind of inform patients what that means, and I think we need to know what that means and to understand how we're using this data, how it's being collected, because the other big term for all this stuff is black box. And so we really do need to understand how these black boxes are being constructed so that we feel like we can counsel patients well. And then the last piece was sort of transitioning medical knowledge from providers to machines and hospital systems ultimately. And how does that blur the line for who is ultimately responsible for decision making? Are you giving machines and hospital systems sort of power to make decisions? Well, then you need to give them sort of structures with which to sort of create a fiduciary relationship with the patient. The patient's assuming you have their best interests. As a human, you're able to kind of take that and consider it. Are we going to be putting that same sort of value structure within the algorithms that we're building? So, I'm not going to go into a full 20-year future renditioning of what this may look like. I'm sure you can imagine how a lot of this technology may be utilized to change your clinic scenario. Maybe the person is identified with a computer vision algorithm and they just automatically get checked in, and all of their wearable device data and sort of sensor data, all of their environmental data is automatically uploaded into a dashboard, and a natural language processing algorithm searches all of the EMR data from the last time you saw them till now and sort of creates a summary for you to then look at and discuss with the patient. You're not at a computer, you're just talking, and then Amazon Alexa is listening to everything and then auto-populating your note, and then based on what you talk about in the plan, bills and orders, and then you just kind of sign off on it at the end of the day. I mean, that's what people are envisioning. When and how and if we would ever get there is very much remaining to be seen. So in summary, artificial intelligence and machine learning are very powerful computational tools being applied in all aspects of cardiology, in everything that we do and across medicine. I think the pro group would argue that the integration of these methods would potentially greatly improve quality, efficiency, cost effectiveness of care. to patients while also alleviating several physician-specific stressors. But there are very, very many significant barriers to the fair and ethically sound implementation of clinically meaningful artificial intelligence. And all of those challenges and barriers really do need to be addressed before any of this becomes mainstream. So that's all that I have. I thought this was a very mean thing. I don't know if anybody can see this. My Apple Watch told me, I think it was talking about the weather, but it says unhealthy/sensitive, and I felt really bad. It was the end of the day, and I was like, that's not cool. I didn't have a lot of time to eat a good meal, and I am a little sensitive. So, but that's some additional resources if people are interested. I'm obviously happy to share slides or any papers that I looked up, and if you're interested, and would love to open it up. I went a little bit longer than I should have. I'm sorry about that, but for discussion or comments or thoughts.
Very nice presentation. It seems like healthcare.
Microphone.
It seems like, great presentation. It seems like in healthcare we are always lagging behind where industry is going. We are having problem in just Dragon to recognize our words. And we talk to Google and we talk to Delta or any other airline. Even with my strong accent, they have no problem understanding or typing things.
Yeah.
And we are using technology that seems like it's 19th century in 21st century. And I'm not sure, I don't know if Google wouldn't have jumped into this retinal thing if we physicians would have done it. And I think somehow our hands are tied up because administration, whatever tools they give us, we use them, as horrible as they may be. Many physicians, I see their notes in the clinics are starting off by saying, excuse, this is, Dragon dictated.
Going to be a lot of errors potentially.
And the errors are there. Yeah. So if we can't work with simpler things, how are we going to make this major jump into AI unless outside industry, Amazon or Google or Apple, they jump into this thing? I'm just hopeful that they will do it because I'm finding ourselves as healthcare providers, we don't have the help from administration to jump forward. Because 8 years back, we had developed and we had checked this thing that people could sit at their home. If they had any symptoms in their leg, they could answer. We had developed about questions. They could answer those questions at home. It took them about 20 minutes. And they would get an accurate idea which test they need. So they could skip one physician visit. And then they could go to the physician with the test result. Or they could put the results in the computer, and it will tell what do they have, arterial insufficiency or venous insufficiency. And I think the same thing can be done. Larry can probably vouch for this. The same thing for lipids. They can punch in their numbers, and it can give them some idea, along with other risk factors, smoking, everything else, weight, and abdominal circumference. Where do they stand? What's there? I think this can all be developed. The problem is it will develop outside because on our daily practices, we don't have the support. Thanks.
Yeah. No, they're all really, really valid points. And I think, kind of why it's a risk-averse field. I think medicine the inertia is there. And so we kind of typically try, even just more advanced traditional statistics methods to get around some of the issues with how we perform regular clinical trials it's been shown that, Bayesian statistics are probably a very beneficial thing to use in how we run clinical trials, and yet very few of them do. So I think it's not going to be solved without some jumping and some leaders, and I think you're exactly right. Although I would say, anybody who's used those like bots to try to get your customer service questions answered, there is some data being looked at. Can the triage call be used as just like you go on and you type in your symptoms and then a bot learns and tells you what to do? Anybody who's used like your Bank of America bot or whatever her name is, I can't remember, could probably, Erica, thank you, could probably agree that it doesn't always work the best that you would like it to, and we probably need to have a higher threshold for what our technology is doing, given that we're dealing with people's health and there may be emergencies and things like that.
So Matt, that was great. two things I think that are interesting in terms of kinds of complications and things that we have to think through with these algorithms. One you got at, which is that one of the fascinating things is these algorithms and doctors are likely to make different kinds of mistakes. Right, so I was on NPR the other day, we were talking about the great example that's now, I guess, in some museum of fooling a self-driving car by basically carefully placed stickers on a stop sign.
Right.
Right, so that car will never blow through a stop sign because it's asleep, but if the stickers, there's two stickers on the S, it won't recognize it as stop and it'll go right through and kill somebody. Right, so one of the things that we're going to have to sort out is what kinds of mistakes we consider legitimate, right? Stickers on a stop sign are a pretty rare occurrence. It's probably the case that if you put that into the population, fewer people are going to die, but we're going to have these what seem like egregious and stupid errors. And I think one of the things we'll have to think through is what kinds of errors are we going to tolerate in medicine? There may be things that look stupid that we would never make at the expense of avoiding a lot of mistakes that we do make. And I think that's going to be a really interesting cultural challenge. The second piece that I think is that's really interesting too is from an ethics perspective. There's a lot of decisions that we avoid making systematically that AI algorithms make us make. So to take the classic example, again, I keep going back to self-driving cars because they're just an easy example, but you can have medical examples that are just, infinite. Right, so the classic would be like the trolley car problem for philosophers, right? You've got to decide, do you turn right and kill 2 kids, or do you turn left and kill, 5 old people? Right? These are things that a car is going to have to. We have to program an algorithm in to say, are we gonna turn right or left?
Yeah.
Right. You have to make those kinds of decisions. And if we have algorithms that require certain kinds of decisions to be made in medicine, we're going to have to make these decisions in a sort of overt way. Whereas now we think now we just avoid making them. Right. Or we let everybody make them, and we don't have to sort of confront the decisions in the same kinds of way. And so I think it's a really that's not a statement about whether these are better or worse, but they're very different kinds of considerations that we have to start taking into account about how we practice medicine and what kinds of benefits and costs, ethical costs we kind of want to bear.
Thank you. I will say I was somewhat encouraged by the fact that there are a lot of like commentaries and opinions that get at some of these issues. So people are thinking about them. The proportion of them is small compared to the overall literature, but at least people are thinking and understanding that these are going to be issues going forward. So that's great.
I think it's just like your autopilot in planes. Boeing had this problem with those MAX
Yes.
planes crashing. And I think you learn, but like in pathology, I've been told that if you show the computer and pathologist breast slide, computer is more accurate in picking up breast malignancies than.
Correct.
Sure, there can be error. Still, the computer is not 100%, but I thought the accuracy of the computer was 87% and the pathologist was 83% or something like that. So I think we can fine-tune these things. There will definitely be errors, and that's why I never think a human being is going to be excluded.
I didn't say that specifically, but I that is my big takeaway from this also, is that the scare of radiologists are going to lose their jobs, or pathologists, or like there was even in JACC Interventions, there was a review about how this technology is going to be used for robotics and like doing It's not going to happen. Like, I mean, maybe it's going to get to the point where a lot of this is automated, but I really feel like there's going to need to be a human component still there at some point.
And we are seeing problems with some of this automation because patient satisfaction, when physician is always looking at the computer screen while talking, is poor. And I personally find it, I want to look at the patient's eyes because there's an emotional aspect, there's a psychological aspect you also want to treat of the patient.
Yeah.
And it becomes challenging. if you're always looking in front of the computer screen and the patient is sitting on the right,
Right.
and you just, to me, that's very uncomfortable feeling.
I was just
Say-
gonna-
Yeah, just really excellent presentation, very balanced and very thoughtful. But I was going to add along the lines, John Rumsfeld, who's the Chief Innovation Officer for ACC, has given some really great presentations about this, and he describes it more as the future is going to be assisted intelligence
Right.
versus artificial,
Right.
and we can never take away the human, component of that and give this up to machines. So.
We've given up a lot to machines, is what I would counter with. So, yeah.
Yeah, I was just gonna say, people do have confidence in their doctor, but as
Yeah.
we've witnessed on many cases, their confidence in their doctors are often misplaced. And I think we have to figure out the way to
Yeah.
balance them, right? We have to figure out the way to sort of minimize the error, use these tools to minimize errors that we can make, but also keep the pieces that matter. And how we do that is gonna be challenging.
Really appreciate it. Thank you.
The preceding program is copyrighted by Emory University.